So I'd like to briefly walk you through back to where Nepal was in the 80s and march quickly forward, summarizing the evidence that provides the basis for preventing vitamin A deficiency, whether it's through supplementation or diet, or in the future perhaps fortification. So we do have questions that we won't answer, at least all of them. Is vitamin A deficiency still a public health problem among children, mothers, and infants? Based on what kind of data, status, or diet? Where does it occur? Does vitamin A reduce child mortality today? In preschoolers, in women, mothers, infants? Are there long-term benefits of early life vitamin A intervention, a cutting edge in science and public health science? Should Nepal maintain, expand, shift, or integrate in a better way vitamin A capsule distribution? And related to that, is there a dietary safety net that now exists in the country for taking some of those decisions? And that's setting the stage for Dr. Ramesh Adhikari's talk a little bit later. So, functions of vitamin A. It does enable vision at nighttime through the retinoid cycle, the visual cycle in the back of the eye. If you don't have vitamin A when the sun goes down, you can't see very well. It's very hard adapting to night vision because of the role that vitamin A plays in that process. It also regulates DNA transcription and regulates cellular differentiation, and therefore it's required for embryo-fetal development, all the epithelial linings in the body to properly function, to replace itself, whether it's the gastrointestinal, respiratory tract, trachea, glandular ducts, genitourinary tract, it's functioning at all those levels. It's needed for immunity, both multiple aspects of the innate immunity and adaptive immune response. It's required for forming red blood cells and for bone formation and growth. And we're finding that just the past few months, there was a paper that suggests that our gut microbiome responds to different amounts of vitamin A in the gut in terms of maintaining a healthy microbiota community. When vitamin A is adequate, all these things go well: bone growth, reproduction, embryogenesis, night vision, immunity, epithelial lining function, and energy balance that we're learning. It's related to risk of obesity, and that brings up the notion of whether it's playing a role in this, what is called the thin fat Asian phenotype, high percent body fat, normal body weight. When you're deficient, there can be aspects of growth retardation, impaired fertility, teratogenesis, night blindness, and the list goes on. And with the immunity problem being compromised, we think that's a key basis for why vitamin A deficiency is an important determinant of child mortality. Well, this is a Beto spot. It reflects conjunctival xerosis and keratinization on the conjunctival surface. What you're seeing there is a patch of cellular debris fed on by various bacilli that can be wiped off of the eye. You can actually wipe that spot away, and what you see is a conjunctival surface that is lackluster. It is not shiny like yours or mine would be when you flash a light on it, reflecting what happens in the epithelial linings of the body as well, because as we know, the eye is not just the windows to the soul. It's the windows to the epithelial linings of the body. If it is bad, if xerophthalmia is in its blinding form, it affects the cornea. And up in the upper left, that is xerosis creeping up from the bottom toward the top of the cornea. That reflects a keratosis, reflects an irregularity, lack of proper metabolism of vitamin A in that tissue, and it can lead to keratomalacia, which is softening of the cornea, which is the blinding condition on the bottom left, that children will develop and go blind from, especially if there's a convergence of poor nutrition, diarrhea, dysentery, severe infectious illness, and in this case, measles. So children who get this condition are very ill. There's been a lot of work in Nepal on the epidemiology of vitamin A deficiency. Dr. Madan Upadhyay, back in 1980-81, carried out a national xerophthalmia survey in Nepal, finding nearly 2% of children with xerophthalmia. That translated into 75,000 children at the time in the country with xerophthalmia, and about 1,000 with potentially blinding corneal disease. Dr. Subarna Khatri carried out epidemiological studies in the Terai, looking at risk factors for xerophthalmia, inadequate breastfeeding, wasting, stunting, diarrhea, dysentery, all familiar risk factors, previous siblings with xerophthalmia or sibling death, low socioeconomic status, and of course a poor diet. Studies in the Terai in the 90s, you can't probably see that, but their foods are listed down the left side, and those are rank correlations between one sibling's diet and the next. So there is high correlation from one sib to the next in terms of the diet. If the diet is poor for one, it begets a poor diet for the next child, and so forth. So this helps us guide the notion that vitamin A deficiency is a chronic nutritional condition that requires long-term solutions. This is a graph from the 70s. Dr. Sinha and Bang in West Bengal carried out a very meticulous study following children for 2 years, looking at the seasonality of toe spots and night blindness. And you'll notice that there are peaks at each time of the year. And so the peaks that occur in April, May, form the basis of why vitamin A supplementation today goes on in March and April and in November, December to cut off the peak of xerophthalmia and to try to have the maximal impact when the risk is greatest. The Aceh Study in 1982 to 84 first showed that vitamin A supplementation every 6 months could reduce child mortality. It had to be answered someplace else, and it was answered in Nepal. Nepal has carried out the best trials in the world to answer the question of vitamin A supplementation on mortality. The bottom line is the mortality curve of vitamin A supplemented children, and the top curve is that of the controls. This was a 30% reduction, and it was followed by another trial in Jumla in Nepal with a completely different mortality rate, showing that supplementation could reduce mortality by 29%. In the NIPS-1 study, we further looked at the interval to interval. On the left side here, every 4 months, the children were given vitamin A or placebo. And you can see that when the trial was underway, it was about a 30% reduction. And it was a 30% reduction every 4 months. It didn't go away. It was a continuous 30% reduction. When we crossed the controls over to get vitamin A, the controls went down to where the vitamin A children were. So we continued to dose and follow these children, confirming the impact of vitamin A in reducing child mortality in Nepal. It's a major finding, a major set of data that has helped guide the interpretation and the action of UNICEF and countries around the world to use vitamin A to reduce child mortality. 30% reduction, whether it's Indonesia or Nepal, it seems to be the central estimate figure. When you put the meta-analyses together for the entire South Asian region of the studies, it's about a 34% reduction. The other thing that happens, though, and this is the only data in the world that's come from Nepal, is that children get otitis media when they're preschoolers. And that is the leading cause of hearing loss from severe infection. When we followed up children in the first trial, 16 years later rather, and did hearing tests, we found out that the children who had discharge, no ear discharge when they were preschoolers, there was no effect on their hearing loss as young adults, as adolescents. If they had discharge, ear discharge, there was a 42% reduction in hearing loss based on audiometry in children who, if they had an ear infection and they got vitamin A, they were less likely to have hearing loss. That is saving the hearing of about 5,000 children every year in Nepal from being impaired later on. And you don't see this being mentioned in the literature because it's only one country, but it sure is an important country, and it's here. Vitamin A supplementation 2001 to 2014, running at 90 to 95%. I was bringing this point up because I saw this dramatic reduction in vitamin A supplementation coverage. And I was thrilled to see Dr. Lamachani's figure that it's 86% in 2016. I don't have 2016 data. So it's gone back up. I was worried, frankly worried, that there was some loss of interest in keeping this program going. It needs to keep going until the diets are improved in the country. Night blindness occurs in women during pregnancy. It is a risk factor for many other conditions that women experience during pregnancy. And it is a flag for women who have a problem, who need attention. They need better nutrition. If you look at mortality of women with night blindness during pregnancy, which is on the left, you find that the mortality rate is high during the maternal period. The night blindness goes away 3 to 5 days after pregnancy, after the fetus and the placenta are discharged. And some recovery of nutrition occurs. But look at during the late pregnancy period, for the whole first year following childbirth and into the second year, there is an excess risk of mortality of women who had night blindness during pregnancy. And it's due to infectious illnesses that they are more at risk of developing. When we carried out a trial in Nepal to look at vitamin A supplementation or beta-carotene supplementation on maternal and infant mortality, we found that there was a dramatic reduction in maternal mortality in Nepal in the 90s if women were given a routine dietary supplement, RDA level of vitamin A or beta-carotene on a regular basis, before, during, after pregnancy, into the next pregnancy. There is also effects on the offspring. This is a diagram showing forced vital capacity of children born to women who were given vitamin A, beta-carotene, or placebo during pregnancy. And on the far right, you can see the children whose mothers got vitamin A during pregnancy have a higher vital force capacity. Their lungs are larger, which is consistent with an animal literature. Then in the placebo, and the beta-carotene group is in the middle. So one takes animal literature and looks to see if you can find evidence in human populations, and when you find it, it brings biological plausibility to not only short-term effects, but long-term effects. I'll go by that slide for the sake of time. But there's also boosted immune responses even at 10 to 13 years of age in children born to vitamin A adequate mothers. Finally, a note about newborn vitamin A supplementation, which has not been carried out in this country, but it has been carried out in several countries in the region. And I bring your attention to Asia, where the relative risk is 0.86. That's a 14% reduction in infant mortality if children get a dose of vitamin A within the first several days after birth. One dose, just like for the older children. That can translate into about 180,000 infant lives that can be saved in South Asia alone every year, including vitamin A with a safe birthing kit as part of essential neonatal care. The diseases that seem to be affected are those that are related to diarrhea, dysentery, febrile infections that kill young children in the first year of life. So, we have to present and think about an orchestrated plan for continuing to prevent vitamin A deficiency. It seems that as long as the deficiency exists in the population, we need to continue supplementation. But at the same time, there are new programs on the horizon that we're talking about at this meeting through agriculture, through improving the diet, fortification. Biofortification offers a possibility in the future, and you put all of these together, and it can dramatically continue to have an effect on child health in this country. So recommendations: maintain vitamin A until the prevalence of vitamin A deficiency in children goes down to less than 5%, which we will find out about in the fall. A dietary safety net is needed that can come from better agricultural practices and the food system improvements. Intensify exclusive breastfeeding. We have to assure dietary adequacy and consider newborn vitamin A for reducing infant mortality. Thank you very much.